मैं एक बार स्वामी सर को देख लेता हूँ, जस्ट रिंगिंग।
आप जब बोलोगे तब शुरू करेंगे। कर लिया जो कर लिया।
अजय स्वामी सर को सर थोड़ा सा मुश्किल हो रहा है ज्वाइन करने में, जस्ट ईमेल करते हैं, then he'll join, then we'll start.
Okay. I'll do it.
I think, sir, Dr. Swami has also joined, so we can begin, sir.
Good evening, sir. Good evening, Smith. I'm so sorry being technologically challenged for delaying you by 3.5 minutes, I see.
No, sir, that's fine.
So, friends, today we'll be speaking on a subject which is, yeah, can you introduce or should we go ahead?
Let's go ahead. I think Dr. Hazra needs no introduction. He is familiar to anybody who has got even the remotest connection to cardiology, whether it is any form of social media or any form of, public information, whether it is
whether
Twitter
that is
or
in
WhatsApp,
India or whether any state of India or outside India.
any state of India, outside India, he is the connection that we have to the rest of the world through Twitter. He keeps putting up all the information that comes, and he keeps us updated on everything, plus showing us some lovely cases whenever there is time. And without any further ado, we are going to look at something a little different from our hardcore cardiology.
Take a minute to introduce Dr. Partha Chaudhary, sir. He has joined for the first time from Delhi.
Yeah. Please, Smith, go ahead.
So I think it's better that he introduces himself.
Dr. Partha, please, the floor is yours.
I am Dr. Partha Chaudhary. I am presently a senior consultant in Kailash Hospital, Noida. It is great to see everyone on this platform. And it's good that you have started this on Friday evening, because on Saturdays, it's a very busy day for me. And I will not be wasting any time. I will request Dr. Hazra to continue his talk on this prostate artery embolization.
Thank you very much. Thanks for joining. Today's topic is on prostate artery embolization. When Smith told me that you present something on coronary, I decided to speak something which is non-coronary, because this microcatheter embolization coiling is important not only for prostate but for bleeding organs, and sometimes the cardiologists they do face this kind of complications after putting a stent in the left main, like a GI bleed, prostatic bleed, or an aneurysmal bleed somewhere. So it is better to understand that this is very simple, and sometimes it can save time and it can save the cost of the patients, and also don't have to oblige your neuroradiologist or the pure radiologist who are very conversant with this kind of technology and technique. Perhaps they are the better person to treat these kind of problems. But sometimes the availability and the time and the most important is the cost of giving their referral, their referral fees, etc., is a problem in private hospital. So that's why one day one patient, which I have put a stent in the left vein, came with severe hematuria. I'll be showing one case, and he developed a lot of clots in the urinary bladder. And when I asked the urologist to operate him, he obviously said, since you have put a stent in the left vein, I cannot operate him, put him on catheter line. And doing a TURP on a patient who has undergone left vein angioplasty day before, it is a very, very high risk procedure, so they would not do it. So I put him on catheter, and I was waiting and developed the infections due to catheter. So I requested him again that after 4 weeks, can you operate him? He said, you have to stop antiplatelet. So second issue came stopping antiplatelet. I said, it is left vein, though I can stop, still I'm a little hesitant to stop. Then I opened the journals and the books. I saw there are a lot of people are already doing it. Not only in India, Portugal people are doing it. Brazil, they have done in hundreds. So it's very simple. And this prostate is a problem of elderly. The mother nature, what does male, like it keeps, it keeps on enlarging your small prostate. If you understand,
everybody is requested to mute their microphones to allow us to hear Dr. Hazra.
Yeah, if you follow the mother nature, which gives me a lot of incentive to think beyond medicine or philosophical. Like if you have a prostate when you are born, it is very, very negligible in size. As you grow, as a male, your prostate enlarges, but opposite things happen in female. They are born with, your uterus, which maybe is very small, large in size in puberty or during your fertile age, that gets smaller and smaller. So one hormone makes it smaller in female. The same hormonal mechanism makes the prostate bigger and bigger. So if you want to go for reverse aging or reverse the sexual life, so you have to make his prostate smaller and uterus bigger. So that is the reverse aging or reverse theory of nature. Now, prostate, that people who has developed this, the symptoms, and they are definitely have some comorbidities like oral anticoagulants. They have COPDs. They have inoperability because of spine problem, or they're not fit for general anesthesia. So for these people, these prostatic artery embolizations is very elegant, and it can give rise to long-lasting relief of prostatic symptoms. So these are the data from China, and these are the data from Brazil 2015. So what they are saying that it is as good as or non-inferior to TURP up to 3 years. And if you have a recurrence of prostatic symptoms, you can always go ahead with a second procedure. And so this can be done again and again. For example, the CABG is a one-time procedure when I counsel them, but some people talk about the restenosis. So some people prefer 3 sticks in the radial artery rather than 1 socket in their sternal bones. So you have to share a decision with the patients, and if the patient agrees and the prostate is of sufficient size, it is not effective for a small prostate. The small prostate, they have some psychological aspect, they have bladder neck obstruction. So if you have a large prostate, whether it's a cancerous bleeding prostate or frequency of symptoms, first time de novo case, or the drug failure, you can opt them this kind of surgery because it is very elegant and a patient can be having relief of symptom. You can take out the urinary catheter on the table, and the next morning, some people, they feel that they could not spend the last night because of prostatic symptoms. And once you do it in the early morning or the daytime, they said, my night stay in the hospital was beautiful. So sometimes it's so dramatic and do not require any blood transfusion, no anesthesia, and no retrograde ejaculations, no sexual dysfunction. So these are the advantages of having prostate artery embolizations in our country. And you have to have that kind of confidence in yourself that you will do a good job and you will occlude all the possible prostatic artery branches. So knowing the prostatic artery branch is of paramount importance. And you know, this prostate is small, as I have shown. It has got dual supply from the internal iliac artery. And if you know that there are certain catheters which can be passed into internal iliac artery, for example, if you want to hook the left internal iliac artery, it is very simple that it can be done from right, and similarly that left can be done from right easily, right can be done easily from the left. But most of the time we do it from one axis, either right or the left. Most of the time it is right superficial femoral artery, right groin axis. We'll go to the left internal artery, and then we come back to the right. And entering into right internal artery is a little tricky with the conventional JR catheter. So what we do, we take a roadmap and take a SIM catheter. The previous video was playing on the YouTube. So you take a SIM1 catheter and you have to know how to shape the SIM catheter. You know, this SIM catheter, if you put it in the ascending aorta, then perhaps you have to manipulate this SIM catheter so that it becomes a reverse loop. So you drag the SIM catheter, then you put it down, and once you drag this catheter on the right side, those who do uterine artery embolizations, it usually hooks into the internal artery. So SIM for the right and usual catheter for the left. Sometimes the right JR also can hook the right internal iliac artery. So it is either a diagnostic catheter or a 5 French guiding catheter will take this pteromoprogate. So most of these prostate artery embolizations or GI bleeding or uterine artery embolizations or a pseudoaneurysm, we do it with prograde. So this prograde, if you understand the prograde, can take 0.21. That means that 0.21 is the maximum capacity of these micro catheter and micro wear. So it comes with a micro wear, and it can take a shape, but not that good because this thermo doesn't have that stainless steel tip. The stainless steel, the beauty of any stainless steel is that if you give a shape like a neurocatheter, what we do for neuro interventions like stroke care, it maintains the shape. But if you do not have this nitinol, if you do not have a stainless steel, if you have nitinol, which is braided in this part, the two nitinol braid, the single nitinol braid, then is a flexible part. So this color gives you some idea that this portion, little lightish blue, and this is blue. So this is quite robust. And if you push it, usually doesn't kink. Usually, most of the time doesn't kink. This doesn't kink. So these are kink resistance because it is nitinol. So prograde has nitinol braiding and double braiding here, and it is up to here. The problem of nitinol, there are some advantages of having nitinol microcatheter and stainless steel. So nitinol, you know, if you just bend it and if you make a loop, and once you release, it comes back to its own shape. And if you have a tortuous prostatic artery, and it can negotiate. It can negotiate like a snake if you have that wire in front of this microcatheter. And echelon is the catheter for a neuro we use. The echelon has got stainless steel, and once the stainless steel comes into the temperature of the blood, and it becomes, and if you give a shape, that shape is usually maintained. So it has a tendency to go in one particular branch until unless you take out the catheter and give another shape. And with time, that stainless steel becomes very, very soft, and you have different cups on this microcatheter, and your microcatheter is gone, you cannot use this microcatheter. So knowing the microcatheter is very important here, and you have to use the same microcatheter thing. Now, if you push this Progate catheter too much, it may jump back. I mean, it may not follow, but even then, you just withdraw it and you negotiate with the wire. The wire travels, then you push it. Now, here and white half is important because white half tells you are pushing this microparticle like PVA. You can see this microparticles are jamming this portion, and perhaps whatever you're injecting, many of these particles will stay here and may not go inside the microcatheter. So this transparent half tells you if you have a coil, you can see that coil is actually traversing, and once it traverses, you cannot see anymore. But if you do not see the coil has gone through this transparent part, whether it is coronary or it is any other bleeding portion, celiac or mesenteric or SMA, you must see that the coil has actually traversed this portion, and then you can push your this pushing wire, like it comes with 2-1 wire. So you usually push this with your 2-1 wire. The 3-5 wire or Terumo wire will not work here because it is 2-1. So if you really want to push a coil of 3-5, then you have to take this diagnostic catheter, 4 French JR or 5 French JR, or a glide catheter or any other catheters, because it can take 3-5. This is not a rocket science to understand that 2-1 will not take a 3-5 coil. So bleeding vessels, we take this diagnostic catheter, but since we're injecting microparticle, usually it is 300 micron. Some people inject 200 micron. At 500 micron to 300 micron, if you mix with 500 to 300 micron of PVA particle with saline, a little bit of dye. I usually do not use dye. I tell you why. Because if you take dye, this is more viscous. It will clog the microcatheter. Now, this 300 and 500, if you have a different size of the collaterals, which collateral may be a 50 micron or 100 micron, some of the prostatic artery may be of size of 300 micron up to 500 micron. So some will go to 100 micron size, some will go to 500 micron size. So all this prostatic artery will be clogged, will be occluded if you have a mix of both PVA 500 and 300. But if you see that a prostatic artery is very small, 300 is good enough. And if you see the prostatic artery is very big, very large prostate, cancerous, multiple sources, perhaps you have to use a coil, and usually it is 1/8 coil, the pushing coil. And once you do the PVA particle embolations, usually we finish with a coil. Now, these are the branches. So knowing the branches is most important here. And it can vary from person to person. To be very simple, if you go for a selective injection of internal iliac artery or a common iliac artery, which divides into external iliac and internal iliac always goes towards the middle, the midline, and external iliac comes to the everybody knows. Any artery which is a very big size, usually not a prostatic artery. Any artery which is very long, is not a prostatic artery. Any artery which is like a screw, usually the prostatic artery or uterine artery. So these screws, this is like a screw, multiple screws, small screws, like ribbon made into a screw, is a pathognomonic or a very classical feature radiologically and geographically, that is a prostatic artery. Now there may be small branches. So this blue is a prostatic artery. It can arise from obturator artery. It can arise from superior vesical artery. So superior vesical artery, so suppose you are injecting the lab, it goes to the middle and this prostatic artery, then it is internal pudendal artery. Now internal pudendal artery is very important for your potency, and if you occlude the internal pudendal artery bilaterally, this patient can develop erectile dysfunctions. Those who have pudendal artery stenosis, usually very simple, you go inside the pudendal artery. If you know that it is ischemic cause, has got pudendal artery stenosis, you pass this 1/4 wire, then you dilate to the balloon, you can put a stent, or a drug-eluting balloon is the current preferred choice for pudendal artery related erectile dysfunctions. So DEB, small DEB works better here because the restenosis rate is also very high with the stent, even it is DES. And the DEB for internal pudendal artery for erectile dysfunction can be done like coronary artery repeatedly. So this middle rectal artery, even if you by mistake, if you inject middle rectal artery, it has got dual supply and it has got a very rich collateral supply. And these are the other forms of pudendal artery, prostatic artery. As I told you, it has to be a corkscrew type of artery that differentiate it from other segmental arteries. Now, this internal pudendal artery is basically comes up to the penis. On the diagram, you can see that this penile artery, pudendal artery, reaches the cavernous os. Sometimes you can see this rudimentary umbilical artery. So you do the roadmap, give a dye, good amount of dye, and you'll see some smaller artery here. Here you can see the corkscrew varieties. This is nicely seen here, and it's making a turn up and down and around. And the more you see, more you understand that it can be seen very easily. And sometimes you may fail, which so after so many branches arising from the internal artery, which is prostatic artery. So sometimes you give nitroglycerin or papaverine. So once you give this vasodilator, and which is usually required before embolizing, because that vasodilator opens up all the microcirculations, and basically you are doing a cell necrosis. So nitroglycerin or papaverine or diltiazem or other things, vasodilator works wonder if you really want to see them in somebody who have not seen it before can see much bigger, and bigger is better. So these smaller branches, sometimes you get a lot of branches there, but as I told you, you have to know that this is, which is going lateral, whatever goes lateral, don't believe that it can be anything which is supplying the middle structure, that is rectum, bladder, and prostate. So any structure, any artery which has got lateral course cannot be your supply for prostate, that penis, or the bladder. So whatever is coming to your community has to be something to do with the pelvic organs, and it can be seen from both sides. So what we do, we actually give this kind of, like, if you have smaller branches, you have to use smaller particles. If you have larger branches, you have to use larger particles. So ultimately, these PVA will be part inside the prostatic tissue, and with time, within few seconds, few minutes, all the prostatic tissue, because of the PVA particle, will be ischemic, will have ischemic necrotic death, and will be dysfunctional. Sometimes you have to come back if you are having a recurrence, and or especially in malignant process, you see this. Now on X-ray, if you put this patient, this III, like AP position, so there will be a void. There will be a void of a bladder, because these patients, they retain urine. Sometimes you can see the police catheter here in the middle. So there is symphysis pubis, and symphysis pubis, you see there is a separation of two bones, and this is a cartilage. So anything above cartilage or the symphysis pubis has something to do with your bladder, and in the middle you have a prostate. So if you see any artery which is visible here, it cannot be prostate. Any artery which is seen here, like beyond symphysis pubis, it may be a corkscrew because it may be a collateral. It cannot be a direct branch of the prostatic artery. So concentrate on this zone, very limited zone of symphysis pubis on both sides, and the prostate is in the middle. So any prostatic artery which is bleeding, causing huge hematuria, if you inject a coil, it immediately stops the blood, the bleed in the bladder, and it could be life-saving in many cases. So these arteries are very small. You can see them better, bigger, as I said, by vasodilatations. Inject the nitroglycerin, then inject the coil or inject the PVA particle. The first nitroglycerin, then take an angiogram, then PVA particle. You can take an angiogram for complete occlusion. If you're not happy, then you can use a coil. Because if you inject forcefully, if you inject in a occluded prostatic artery, it will regurgitate, it will vomit its content like PVA particle into the internal pudendal artery. If it goes to inferior gluteal artery, nothing will happen. But if it goes to only like if other side is atheromatous of having atherosclerotic disease or occluded internal iliac artery because of some reason, then it can develop some ischemia, some prostatic necrosis, but usually it takes over by some collateral from somewhere like rectum. So rectal necrosis, if you do not have any circulation from other side, and if you occlude all the rectal arteries, all the vesical arteries, this is very, very rare, you can form a ischemic zone of bladder, but bladder is supplied bilaterally, and it has got rich collateral from other sources. The smaller arteries, actually superior vesicle, middle vesicle, inferior vesical artery has 3 arteries or 6 arteries, and middle rectal artery, anterior rectal arteries. All these arteries to be blocked by simple embolisation is very rare because you have so many branches. Sometimes, you know, the gynae people, once you have PPH, like a postpartum hemorrhage, they occlude both the internal iliac artery and they tie it. Patients survive the initial insult of PPH, and they do not develop any bladder ischemia or rectal ischemia after having complete occlusion of both the internal iliac artery. So internal artery and its branches has got a very beautiful dual supply, and you have to understand that this is basically a selective occlusions of the prostatic artery. So what you see here, there is a collateral coming. This is the bladder, and this is collateral coming here. Actually, if you inject hard, you can see the collateral of the right side. So if you inject hard, these smaller collateral also will be embolized, and immediately you will see that it will be very difficult to see from the right side. So don't inject very hard. You can always come back from the right side again, and you can always do a selective injection here, you can occlude the prostatic artery. Now, how much you give? So once you dilute, then it is mandatory to take only 1 cc of this PVA particle, and usually the dilution is around 10 ml of normal saline. It put in the whole vial of your PVA 300 or 500. We just started, and we inject very small quantity, 1 cc, slowly into the prostatic artery. Immediately, it has to be followed by a normal saline injections, 2 to 3 cc, at least 2 to 3 times. Otherwise, that even the newest prograde catheter, you won't be able to pass the second injection, or you won't be able to pass the guide wire, because it will, like, you know, this what we use like a glue in the brain or other arteries. If you use those glue, immediately it holds, occlude the microcatheter. You have to take the microcatheter out. It's very difficult to flush it, and you have to take another microcatheter. So it's very important, 1 cc, just 1 cc injections, followed by 2 to 3 cc of injections of saline only. pure saline, repeat it 2-3 times. And once you see the loss of resistance, the microcatheter, the saline is actually purging with ease. If you have a microparticle, it takes time because there is a resistance, because these are particle. So once you flush the microcatheter, the saline, the second injection is very rapid. You know that microcatheter is now free of PBA particles. Some particles may be remaining into the white part of this transparent plastic hub I have shown. So once you give this saline, this particle will keep on going inside the microcatheter and it will automatically go slowly. So it takes time, at least 10-15 minutes for occlusion of the one-side artery. Sometimes in one injection will occlude whole prostatic artery. But problem is if you inject very hard, then it will regurge, will vomit into the internal artery. So like this, a common trunk, this is the superior vesical artery, this is a bladder, the inferior vesical artery, or it may be a prostatic artery. So this prostatic artery again sometimes comes as a common trunk. So this kind of road map is very important. Now we take this Lual lock syringe. Usually the Lual locks you cannot inject with a normal 2 cc syringe. This PBA particle, the Lual lock syringe is very important. That 1 cc or 2 cc Lual lock, like neuro injections, we use a Lual lock. And now this is police. You can come up to here, nothing will happen. There is no chance of rupture and death because these are do not have any like any area where it will bleed to death. These are very compact zone and there is no chance of hemorrhage or like pericardial effusion in the coronary artery. There is no empty, there is an open space here. So automatically, if you take this patient to MRI, you can see this infarcted zone, and it can be bilateral, it can be whole prostate. So these are the collaterals I have shown here, and coming from left to right. And some people, they do take CT, and they have the luxury of having paraoperative CT and paraoperative with US PAE, they do it. So there are different varieties I have shown here. And this is the first patient. You know, you have to speak to the patient that, and he was my first patient, elderly patient, left main angioplasty, and he was very happy. So in life, you see that this is a microcatheter. You can go selectively into this. And this symphysis pubis I was mentioning is very important. So this corkscrew, which is coming here, not here, not here. You can see some small vessel, but whatever is coming here, it's the last branch. You have to enter the last branch here. So you have to keep on traveling with your microcatheter, your roadmap, the micro wire or 2-1 wire. So you pass the wire there. There may be a spasm initially. You give nitroglycerin. You can defeat the spasm by nitroglycerin. And on the top of spasm, if you inject, nothing will go distally. So you have to break that spasm, then only go distally. Wait for a few minutes or pull back the microcatheter a little bit. So start from here and slowly you inject. Distal you go, lesser is the volume. Proximal you go, larger is the volume. So maybe 0.25 cc here, maybe 0.5 cc here, maybe 1 cc here will work. But if you inject here, this will occlude this vessel. If you inject here, it will be much more selective. So it's not a rocket science that if you go distally, sometimes it's much difficult to negotiate. But in long term, I am so happy. I have an experience of doing this type of cases around 40, and mainly elderly. I have never done it in young patients. And those who have opted for this, those who have been referred by the urologist, those who had bled, and those who are not willing for surgery, these are the people who can have this kind of therapy. With this, I'd like to stop here. If you have any question, it will be my pleasure to answer those.
There are a few questions in the chat box.
Yes. So in chat box, do you do CT, MRI, angio to delineate? Yes, as I told you, if you are having this facility like hybrid lab, you can do this. Usually, I never done any CT angio or MRI angio. If you have MRI angio or CT angio, then perhaps it's much easier to locate. The anatomy is in front of you. But if you do not have those kind of luxury, because it adds to the cost, on the operative table, you have to search, like you have to go for maybe selective injection. You have to spend some time to find the exact obturator or your infragluteal or pudendal artery, where from it is arising. So pre-CT or pre-MRI gives that kind of idea. Requesting to participant when you not speak. Okay. So that's not a question. Okay.
Will ultrasound contrast will be helpful. Obviously, we need a radiologist injecting ultrasound contrast and delineating prostatic artery, whether we are in the right space, we are selective or not. Will that be helpful, like we do in HOCM, something like that?
No, it sounds very elegant, but the cost, the availability of. I asked one day Ajay, so how do you do, because he's a master of hypertrophic cardiomyopathy. He told me something else, because that cost of that contrast is very high. You can use this agitated bubble, as Ajay taught me. So I use occluded balloon and agitated bubble to delineate. Dextran can be used. That hemoxyl some people have used with agitations, but contrast, I don't know, I don't use it because it is so simple to see in your own angiographic method. And as I mentioned, the corkscrew is the pathognomonic of uterine artery, reproductive organ supply. It's not seen anywhere in our body where you have a corkscrew type of capillaries, smaller arteries. Like you can't see in the kidney, you can't see in the heart, you can't see in the brain. It is seen only in the prostate and the uterus.
I think that's a wonderful question, actually. I mean, if we are trying to become more and more precise, both these techniques might help us. But I was wondering on the angiogram itself, Hazra sir, is it possible for us to make a protocol wherein we look at both internal iliacs and decide which is larger? I was just going through literature. Sometimes there is significant variation in the size of the relative size of the prostatic artery from either side. So I was just thinking, if we make a kind of a protocol that we look at both sides and decide which is larger.
No, you have to occlude Ajay both sides. Otherwise, there will be collateral. Left becomes right becomes left.
Right.
And they will join hands and they become Congress.
Then they become right. So tell me, on an average, how much time does it take you after a little bit of experience?
Yeah, that's a good question. If you are actually, that should be the last case, sometimes, because it does take time for initial few cases. But once you become expert, half an hour to 1 hour is job to finish. You have to have a good technician. He can point out on the screens that this is the prostatic artery. So you have to train the technician, because if you're tired, sometimes it takes a lot of time to identify. So once we know, like first I read in the anatomy book, what is prostatic artery. Then I saw some YouTube. Then I did some angio on my own. Then I talked to the radiologist on CT scan, how does it look? So if you've seen few cases on YouTube, or if you have a radiologist in front of you, and they can tell you, look, this is the prostatic artery. They can identify that the radiologist, look, this is the prostatic artery, because they see day in and day out.
I was writing down angiographic views. I was trying to search literature. What kind of angiographic views are best to identify blood supply? So do you have anything to add from your experience?
So oblique views sometimes, can give rise to the exact origin, because you have to enter selectively into the internal pudendal artery for pudendal artery stenting, or a bleeding prostate. So oblique view, RAO, LAO for left oblique view for left prostatic artery, right oblique view, right prostatic artery. But I tell you to keep on playing on the view, you get confused, because so many arteries are there. So now I have decided whatever is seen in AP view, that will be in front of my mind, in front of my eyes, and I'll try to focus my eyes only on AP view. Because once you move the camera, because this roadmap usually is a fixed kind of thing, you have to work with roadmap. Once you move, then the memory is actually lost. Dr. Bali is here, sir. Good evening, sir.
Very good evening, Dr. Prakash. It's a pleasure listening to you and listening on a new topic. Absolutely
Yeah.
mesmerizing. Great job. Keep rocking.
Yeah, actually, to be very honest, I'm not scratching his back. All these things I learned from Dr. Bali. Maybe he not be knowing, but I was following. So he's the man who started doing this pulmonary valve angioplasty, thinking beyond coronary carotid. Sir, you used to do carotid and brain artery angiogram, etc. So one day I thought, why not? Why all the time I have to invite the neuroradiologist for the carotid angio? If I can hook coronary artery, what's the big deal of? Then from there, gradually I learned that peripheral also can be done. We can do a good job on peripheral artery. So from carotid, he is a master of aortic arteries, and he has done many cases. From there, subclavian also. So from subclavian to carotid to abdominal aorta to internal iliac to SFA to below-knee to prostate. So on and so forth. So it's a big, those who have got their training from PGI, they can push their NFL up anywhere. I mean, it is not like US or Europe that you cannot touch the pudendal artery, you cannot touch the prostatic artery. If you have the confidence and knowledge, if you're training from PGI, you can do anything if you are comfortable, if you have passion, and if you have enough wisdom to help people, because you are the person who can help patient directly, because it is your headache. If somebody bleeds from prostatic artery, as I told you my story, nobody is going to help you in the middle of the night. The next morning he's bleeding profusely, come and help you. They will say, give blood and wait for 1-4 days.
Hi, my name is Hitesh, sir. I have a question. How do you select your patient and what do you counsel your patients? Like, what can be the potential complications and what are the backup plans for those?
Okay, so first of all, those patients who are living a catheter life and they want to get rid of their catheter, and they are because they are living on a catheter because the urologist, they did not offer him surgery because of high risk. So these are one group of patients turned down, surgical turned down, like any CABG or valve, like TAVR, etc. Second group of people, those who have bled, like inferior MI, you given thrombolytic therapy, next morning you started bleeding. Left-band stenting, next morning you started bleeding. So will you send them for surgery? Nobody in this world will operate on this patient. They will say, in urination, that irrigation, deep blood, etc. Third group of people, those who do not want, this is their choice. This is shared decision making. You must exclude bladder neck obstruction, and you should not include small prostate. Small prostate and the prostatism has many mechanisms. And those who have impotency, these are the people who should not be tried, because if their impotency gets aggravated, which is a possibility, because if you include this internal pudendal artery embolization during the process by mistake, that will add to that problem. So those who are thinking about sex, there are many people who talks about sex even at the age of 75. We must be very aware that they are still having those kind of my mindset that my sex is very important, erectile function is very. This is a psychological thing, but sometimes it's real for some people. So these are the group of people who should not try prostatic artery embolization. Those who are allergic, those who have undergone a major pelvic surgery, because you cannot find the prostatic artery in there.
Is there a particular prostate size which you choose?
30 gram and above. 30 gram and above is the ideal size. And residual volume of urine should be there, but pure residual volume may not go up, because if you have a bladder neck obstruction or a dysfunctional bladder, you can have still residual volume of urine. So check the size, uroflowmetry, rule out the bladder neck obstruction, psychological thing, then you can take this up. But you should have a urologist friend who do not mind sending few of their patients whom they cannot operate. So these are the right patient medico-legally to go for prostatic artery embolization.
So the Foley's bulb that you have shown in one of your slides, is that for localization? Do you fill it with contrast?
No. Foley's like on your DSA. If you take the DSA, the Foley's bulb can be seen nicely. You don't have to give contrast. Even the simple saline, and it is an outline of the Foley's you will see. You're not going to see the content of the Foley's. So on DSA, that becomes a marker of your lower end of the bladder, or the bladder neck. So prostate starts below. So that police bulb can give you some idea if you are actually starting your prostatic artery embolization career.
And I see that you were telling about the ProGrade catheter. Is that the microcatheter you usually use?
Yes, a ProGrade microcatheter, as I told you, look, it has got braiding, it has got nitinol, it has got transparent harm, it has got 2-1. So if you really want to fix the coronary perforations, suppose you, coronary distal artery perforations, you have to understand the ProGrade catheter is less costly, a little bulkier, but 2-1 wire, which is usually not required for coronary, usually 1-4 wire. So ProGrade will take 1-8 coil, 1-4 coil, 1-10, 1-0 coil. But ProGrade will not take 3-5 coil. Understood? If you want to use this fine cross microcatheter, there in coronary artery, you still can use 0.1 bit coil. But ProGrade, the beauty is the less cost, more robust, and you can lot of push and doesn't kink, and easy to handle. And this is a preferred catheter because it's braided, single braided, double braided, triple braided catheter, and the internal lumen is also now is increasing. I think the latest ProGrade Pro will be much luminous than the ProGrade what used, but it is little costlier, 40,000.
And you mentioned about the mixed bag of the particle size you choose. Does your decision to always inject the mixed sizes depends on the collaterals also?
If you embolize like a splenic artery, then you have to use more than 500 or a coil because splenic artery is very big. So splenic, like suppose you want to embolize uterine artery, is very vascular and big artery. So you have to use 500 plus. This prostatic artery usually of 100 micron to 100 microns. So 1.5 times the size of the artery should be the ideal micro particle size. Anywhere, even in brain or other arteries, if you really want to occlude, you have to know the size of the particle. Now, if you mix 500 plus 300, 300 will go definitely to a more distally and smaller artery plugging. 500 you will get occluded at the mouth of the transition zone where the size of the diameter of the arteries changes. So it automatically will spread in different directions, and it is like a swirl. And if you move with the flow of the blood or the saline, where it will be parked according to the size. So you can stack or you can design the microparticle clogging if you have a mix. And most of the time you use 300 micron, and we mix with 1 or 2 coils, 0.18 coils for bleeding or complete occlusions of the prostatic artery. When you have a very large cancerous growth, like a bleeding artery profusely, you can see a lot of branches there. And perhaps occluding the mouth with the 1.8 coil, 1 or 2 coil, will do your job. But distal, but PVA is must, because if you give only coil, it will cause ischemia. The collateral will, the arteries can degenerate its capillaries and branches again, and the prostate will be same again. So we are doing a chemical necrosis of the prostate, giving this chemical agent, the alcohol, like Ajay is the master of hypertrophic cardiomyopathy. The same thing, same applies. There you give only absolute alcohol liquid. Out here you give particle, because the particle actually travels in a different direction and stays there for a few seconds, unlike the myocardium.
Thank you.
Superb. So just one thing, alcohol is why we use in hypertrophic cardiomyopathy is that we assume that it is an end artery, which is not always true. But most of the time it's true. And, it is one of the prerequisites that you ensure that the RCA is not filling retrograde from here. Particles have the advantage that they are likely to stay in the vessels into which they're injected. It will stay in the smallest size in which it can and occlude those vessels. So it has the advantage that distal embolization is not really an issue with PVA particles. And I was interested in your, you would first put the particle and then put the coil, isn't it, Dr.
Yes. Because if you occlude the artery with the coil, nothing will go in.
Beyond that, it will not go. Right.
It will not reach the distal bed.
Right. And I haven't really used Prograde much in the coronary circulation because most of the time the other size, 2.1 we used to use earlier. And in fact, in case one has to use coils in the coronary, the neurointerventional coils are fantastic. They come with the microcatheters, and you can deliver them anywhere into any part of the
Angiodysplasia colonic, the reverse. You put the coil first, because if you give a PVA particle in colon, there will be a lot of areas of necrosis. The gut will be necrosed. So PVA is not intended for a gut bleeding like angiodysplasia or bleeding tumors in the gut. So they are part PVA or glue or a sponge, like the sponge that is
gel foam.
Gel foam, you cut and make a fillet, you can inject. Those things are good. But if you inject PVA particle, that will cause huge necrosis. So never ever use PVA for gut. You can use for liver, you can use for spleen, but not for gut. So solid organ, you can use this PVA particle and a coil, mix of like even that AVP, AVP2, AVP3, the vascular plug can be used in large vessels like splenic artery, the hepatic artery, superior mesenteric artery, inferior mesenteric artery. But particle you should use only for solid organs.
I think particle coil device, depending on the size of the vessel that's available and the accessibility also. There are certain anatomical challenges to delivering devices. Bali sir is, as Hazra sir said, has taught us all about reaching inaccessible part of the circulations with a combination of different techniques. So
No, it's absolute pleasure to listen to all of you and doing so much better and so much more than what we were able to do. And Hazra is doing a wonderful job. Great. And you are a master, no doubt about it.
Got inspiration from the Ashoktamma, that is PGI. And we are all proud of you.
Giants, as Churchill said.
Yeah, I mean,
So we are eager to see your case also today, I think, before we are eager to see the use of, So the stage is now yours.
You have time?
Yes.
Please don't tease us. Please show
always have time.
So if you have time, then I will present two cases today. Okay.
Right, sir.
One which I asked about some days back, and then the other presented some time back. Now, a first patient is a 74-year-old male. He had a bypass surgery in let me put it on the slide mode. Can you see my slide, please?
Yes, sir. Please go ahead.
Okay. 74-year-old male had a bypass in 1988. He had a redo CABG in 1998. In 2014, he came to us when I was in Fortis with acute coronary syndrome. And we found that the SVG graft to distal PDA was a large graft, and the PLV arising from that PDA, the PLV part was a huge vessel, and we had to, that is where the lesion was, and we treated it with what we call at that time as Z angioplasty, through the SVG going back into the PDA and then integrate into the PLV. He presented this time with recurrent chest rest angina about a week, 10 days back, and he had acute coronary syndrome. And this is what we found, that he was otherwise hemodynamically stable. And this is the angiogram. The left system, you can say the main left main is diseased, and there is a LAD occlusion. And the problem was in the SVG graft, the one which we had stented. And I would like you to concentrate on this graft. You see, this is the SVG graft, and then this is the PDA, and it goes back, and then there is a PLV, which is large vessel. And we have stented this portion of the, from here to here, we have stented by 2 stents. We had gone from here back, done angioplasty. This is where the lesion he had earlier, and this was extending right up to here. So we gone back and done an angioplasty stenting here, 1 stent here, and another stent here, which was telescoped. And now he came with a lesion, critical lesion here, and he had an ISR in the previously deployed stent. So which I thought was a challenging thing, and I should share my experience with that with you. This is the radial artery graft to LAD, and then there was a Lima to OM. So this is how I went ahead. We took a AR1 guide catheter, took in a guide liner, went down the SVG graft and then passed with a field direct wire, and we were able to cross that. And then subsequently we had a little problem in negotiating balloon. So first took a 1.5 balloon, then we did a buddy wire, took a 2 millimeter balloon, 2.5 millimeter balloon, and it was okay till this time. There was not much of problem. And we're doing dilating with 2.5 millimeter balloon, and then this is 2.5 millimeter balloon. But negotiating the stent, which expectedly was a problem. So what we did was that over this wire, I have taken this guide liner right into the branch. So this is a guide liner into the SVG graft, into the retrograde, into this. And then we were able to do the angioplasty and put in a stent. And the second stent was again a problem. So we had to again negotiate the same guide liner distally, right across, and put in a second stent. And then we post-dilated with 3 millimeter balloon. We did have a compromise of the PDA, but we knew that this was a little lesser small branch. And so that is what we have found, and patient was discharged 2 days later. So use of a guide liner, right retrogradely going into the, what we had previously done only with the guide catheter, because we did not have a guide liner at that time. I had taken the guide liner at this time, but I had not taken it across. But this time it was interesting, so I thought I would share this experience with you. This is the second case which you're talking about. That this is a SKS technique, a 3 millimeter stent, 3 millimeter stent into the LAD, a very short left main, and a 2.5 millimeter stent into the circumflex. And this stent in the circumflex was hanging outside about 3 millimeter. And she came with acute coronary syndrome, and she had rest angina, multiple episodes. First, we thought that maybe this is too small a vessel to do anything about it. This angiogram was done outside. And obviously for this small vessel, you would not like to consider a bypass surgery. So as Ajay had suggested, we thought that some sort of a crush may have to be done. So we went with that. So I said, let me take 2 guide catheters, 6 French guide catheters, and take a JL guide catheters, because that will give me a better hooking. And we took a JL4, 3.5, with which we could hook the LAD easily. And LAD was nice. There was no problem there. And then we took the second guide catheter. This is all the diagnostic, and this is the second guide. And this guide, we were able to see the circumflex, but it was up from outside the struts. And we passed a wire, which easily went on because it was 3 millimeter hanging outside. So this is almost 4.5, and this is 3.5 GL catheter. And this is where we pass a wire. And then I took a 1.25 millimeter balloon, did a stent boost. We knew that we were through the struts, but I dilated the critically narrow lesion with this 1.5 millimeter balloon without dilating the struts. And I also took a 2 millimeter balloon and did not dilate the struts, just dilated the lesion. And then we took a microcatheter, angled microcatheter, and we drew this catheter out into the sinus, and we had a significant area here to work on. And this angled microcatheter was outside this thing, and it was loaded with a wire, but it went ahead. And then we tried to hook, this is a angled microcatheter, and we tried to hook it without any wire. And we were able to have that hook up that struts, and then we passed a wire through that. And then we tried to negotiate this microcatheter quite deep to be sure that we are inside, and this is where it is across the lesion. And then once we were sure that we are there, we did a stent boost here, then we took it out with a dock wire, and then we took a 2 millimeter balloon to be sure that we are actually in the struts, through the true lumen. And then once it was done, then obviously there was not much of a problem. We did a kissing balloon angioplasty. And this is a kissing balloon angioplasty. And then we decided to debate it, whether to do a DEB or to do a drug-eluting stent. So I chose a drug-eluting stent because personally, I'm not very big fan of DEB. I am not impressed by the technology of DEB, but we can have a discussion on that some other day. And then I chose a small stent, about 2.5 millimeter into 15 millimeter, and deployed it inside the first stent. And that the hanging part was not there. This is a previously hanging stent. And then we deployed it inside the first stent. You can see the stent being deployed inside the first stent. Then we did a kissing balloon, 3.5 and 2.5 millimeter, same balloon. Then we dilated it. And this is what we had. So nothing exciting, but surely a little challenging. So I thought I will share these two cases with you. Thank you. Any comments and questions from the expert panel?
Sir, what kind of
Second case,
microcatheter was that?
in second case, why sometimes you can get caught with the stent, and perhaps you have to go beyond the stent strut by a guideline. Though it can be done the way you have done.
Say that again, maybe the guideliner?
Yeah, I mean, you have a stent in the first place, I suppose.
Yeah.
Yeah. So you are going through the start of the stent.
Mm-hmm.
And then if you pass a stent, if you're not able to negotiate the stent beyond that start, sometimes you may not be able to take the stent out. I mean, it can get caught.
No, I did not take the stents there. When I had gone through the studs, we just took a 1.5 and 2 millimeter balloon. And then we went with an angled catheter with a different system. That wire was left there only. We went with an angled microcatheter. Now that
Sir,
angled
you
microcatheter,
have gone through the starts. No? You've gone through the starts. What I'm saying.
No. We went to the studs first time.
First time.
Okay, the second time we have gone through the main mouth of the stent. That was the whole issue of this case. So we did not take the stent through the first stent. That was one of the options, that if you are not able to negotiate it, then the way we crush it, normally, we can dilate the studs and we can put in a stent, and that we would have a cauliflower-like picture in the left main, which would not have been a very good idea. So we gone through the true lumen of this stent. And this angled microcatheter without a wire in the not outside the microcatheter, is how we are able to hook it. The previous guide which we had taken, through which we had gone through the studs, was keeping me close to the origin of that stented segment. And so I had an angle to work on without the guide being too much out. And from there, with the angled microcatheter, I entered into it and then passed the wire.
You have used Supercross 90.
Yeah, we crossed with the BMW. There was no problem. But once we had a microcatheter in, and we checked it up, microcatheter was going smoothly. Then we took a balloon. We did multiple views to have a stent boost to be sure that we are there through the true lumen, and then there was no problem.
So what is the angle of microcatheter?
I think it's about 45 degrees, and it comes in two shapes. In fact, there is a little more angle also. But it's a very useful device, and I found it very, very useful. Even in, sometimes you have a circumflex which is going almost back, and you may have a stenosis or a total occlusion just at the origin of that circumflex. In such a case, go with an angled microcatheter, just hook the artery, and you can cross the lesion.
I mean, those who are listening, for Supercross, you should not use 45 degree, though he is successful. Once you put a wire in 45 degree, this actually becomes 0 degree. If you put a wire in 120 degree, it becomes 90 degree. If you put a wire in 90 degree, it actually becomes 45 degree. So I would suggest the standard will be 90 degree most of the days, because the straight, actually the tip becomes much more straight, and once you have a smaller angle. But if you have a smaller,
you're very right that in case we are using the wire beyond the lumen of the microcatheter, then the angle would probably straighten off. That is what it does. But here we have a wire well inside the lumen in the microcatheter. So the angle is maintained. Once we have hooked up with the microcatheter, the true lumen, then we are passing the wire.
So he has used the microcatheter to hook the stent, Dr. Hazra, probably using stent boost, etc. See, this is as Smith said, his thinking begins where everybody else stops. So the only thing is that when the next time when this lady comes, she must go back to Dr. Bali only, because anybody else is going to end up deforming that stent, into a crumpled mass of metal in the left main. So it's really
so kind of you, but it is. But there are so many good masters here, and I keep on learning all the time.
Elegant case. So another disadvantage of using a guideliner, Hazra sir, when there is a stent hanging in the aorta is you will end up with longitudinal deformation of the stent which is in the aorta. You see, the problem here was there was about nearly 10 millimeters I mean, maybe 6 to 8 millimeters or so of the stent hanging in the aorta. The whole point was how to get past that in a way that was minimally traumatic to the left main and leave as much of a true lumen and as much of straight flow as possible. I mean, I would have done what, we thought, that I would have crushed it and left maybe a little bit outside in the left main, because it would have made for inexpert and unskilled operators like us second intervention easier. But this is a more elegant and a very, very, how do you say, different way of thinking. So that is what we are all here to learn from the master.
No, I would just suggest that we get many cases where the stent is hanging outside the lumen, and right corner it is more common, ostium
Yes.
hanging outside. And in those cases where we have an ostial occlusion and the stent is outside and there's a critical narrowing of the RCA or the totally occluded vessel, there you can use this technique very well, in the sense that you have a, even if you go one wire which goes through the studs,
Yeah,
then you have a guide catheter very close to the ostium, and you can use this micro angle to get into the vessel.
Yes.
So this is what I think the utility of this technique would be in coming months and years.
Fantastic. It's really wonderful. And I think it's, and the other thing about drug-eluting balloon, I mean, a brave man will counter Dr. Bali, but in 2014, we had done a study of drug-eluting balloon for focal ISR. And we published our first angiographic follow-up actually at the end of 18 months. And for focal ISR of a drug-eluting stent, I think it's not such a bad option. It's just that one must cut it before and then deliver with the drug, and it seems to give as good a result as a drug-eluting stent. But as I said, I'm not sure.
Ajay, my problem is that when I don't believe in drug-eluting balloon, I get a review article on Deb. And I'm sitting on that article for 4 weeks to see what I'm going to do with that.
I stopped believing review articles. I'm just telling what we did actually.
Yeah,
and we actually followed them up angiographically, and we found that it's good for focal ISR. 18-month patency is pretty good. But if you have diffuse ISR and other things, now I think imaging has changed the whole picture, and we know in which situation it works theoretically. If you have neointimal hyperplasia, you cut and you use a DEB, and that's the best option. You have neoatherosclerosis, we go ahead and put in another stent, and you have mixed, then you see what you want to do. You have under expansion or a stent fracture, all this which we can diagnose now, or at least come close to diagnosing. But simply brilliant, fantastic.
Thank you, Dr. Hazra, for reminding me about carotid, because we were the first ones to do the carotid angioplasty stenting in the country. Presented that in 1997. And Ajay, were you born at that time?
Not in cardiology, sir.
I am seeing medical profession.
Yeah, definitely.
Okay.
Good, sir. I'm not so young as I see.
Presented that case in one of the conferences, or Matthews Conference, Asia Pacific Intervention Council, probably 1997 in Chennai. Yeah. And then I presented it in Mumbai, and Ashwin Mehta was there. And he said, "Where did you get trained? In which country?" I said, "Ground floor, cath lab, PGI." In those it was with them. And that was the same time when we started the Takashu arthritis, and there were a lot of objection from experts on Takashu arthritis that stenting is not going to work. I remember presenting about 5 cases in 1997, CSI Calcutta in the Science City. And yes, we had Dr. Sanjay Tyagi, and we had other people in the Anshul Jain presented the case. And Dr. Sanjay Tyagi said that this is absolutely useless. You don't need a stent. And what was surprising is in 2017, Dr. Sanjay Tyagi was presenting his series of stenting, and I was a chairman. So, so that was interesting. So sometimes things do come back to haunt you. But those were interesting days, and I owe everything to PGI, and I think PGI has been the greatest institute. He said, Hazra very rightly, that is where the knowledge flows. That is where from knowledge flows, and we can't thank enough the institute we have got training.
So
can I ask a question regarding the second case you had?
Sure.
I'm very intrigued by the use of the 2 guides you use. So do you have any tips for, like, which are the cases where you use these 2 guides, and do you use different curves, or you use the same like JL4, JL 3.5, or you will use different
See,
catheters?
I use these two guides quite frequently now, but first I started when we had a left main trifurcation lesion. And we said that when we're going to do a tracing, instead of using a 8 French guide, let's use a 2 guides. And you use a 2 6 French guides from either a radial and the femoral root or both the femoral root, and the process becomes that much more simple. In this patient, we used 2 guides because the hooking the circumflex was going to be different. There was no way we could have done with 1 guide without going through the studs and crushing that particular stent. So we used the first one, which is a 3.5, JL 3.5, which hooked the left anterior descending artery, and we use a 4.5 for hooking the circumflex. So they were definitely different curves thing, and it depends on how much is the angle of that particular vessel and what is the aortic root size and other things. But you have to use it 2 different. But 2 guides are much easier, much more you don't have to use a bigger guide, and you can easily use 2 balloons or 2 strands and do. So I use it for when there's a trifurcation of the left main, or when there is a I'm going to do some kissing things or so. But that is what I use it. But I think it's a very useful way of going on.
Thank you, sir.
I rarely use a
it?
JL now. In PGI days, I used to use a lot of JL guide, but this was one of the rare occasions where we used a JL guide.
And did you patent this, sir?
My other patents are still not patented. So I think this is an interesting technique, and if all of you do find it, this use of microcatheter to hook a overhanging stent in a ostial critical lesion, then probably we can offer it as a solution. And we have, I don't know whether I've shared with you or not. We did describe a technique of ostial stenting, the use of a guide liner to nail the ostium precisely. Although in the LAD it is not that useful because ostium of the LAD is rarely alone involved. You will have a disease extending into the left main. But if you have a LAD and diagonal, or you have a PD and PLV, or you have a circumflex and OM ostial lesion, that guide liner can be very extensively used to nail exactly the ostium. So there are a few small little things which we keep on doing, but you probably do much more than I do these days. That is what I would say. Then we had made a bloodless things where you could not, where there's not a single drop of blood which comes out when you are doing a puncture in patient who have viral infections and things like that. So that is awaiting patenting. So we had a single wire double balloon technique, which we described while doing a extensively occluded subclavian artery. We went from the femoral one and the other from the brachial, and we inched with 2 balloons to take care of that. So that was at that time called 1992 when we did that. That was a Searle Award. There used to be Searle Award in those days. So I came number 2 because the chairman at that time said that this cannot be replicated. So that can't be an excuse for not giving the award. So that was a single wire double balloon, and it is in literature by Bali's technique. So there's small little things which keep the old man going.
Hardly.
It's always a pleasure listening to all of you. And Hazra in structural heart disease is doing extremely well, and we keep on listening to him. He's proctoring in different part, and his visit to All India Institute, and probably if you go as a proctor in an institute like All India Institute or PGI, that's a greatest achievement for any academician, I must say.
Yes, and the first case also I saw the retrograde flow from the dye injection refluxing was actually showing proximal RCA, quite up to the mid RCA. So I was wondering why sir didn't do the native RCA.
His native, he had an ostial occlusion, and there was a stent at that place. But maybe next time he comes back, I would have no other option but to then call you and go after that native right corner.
Yes, I will do a retrograde from this backwards and then fix the PD from there also.
Absolutely. That's a very good way of going about. That's very good. You seen that case where we gone retrogradely from the native coronary to the SVG ostial?
To the SVG ostial.
SVG ostial.
Yes, sir. Yes, sir. Even this case I have seen, sir, last time when you had shown us this this PDPLB combination.
Yeah. So this is an extension of that.
Yes, sir. Yes.
So, no, but getting this guideliner right into that branch was a interesting.
Not at all.
And we had Naveen, Professor Major General Naveen in the lab. So it's a pleasure to have him.
Yes,
along.
yes. I also had the pleasure of working with him for a year, the happiest year of my service career, I feel. We had a great
I think he
time.
should be also active here. He should be.
No, sir, you must push him. He should be
Yeah.
here on this forum.
Yeah.
He's also.
I think he's there in the forum, but he has not had the opportunity to present something.
No,
So I'll push him to.
Yes, sir. Yes,
We can have him the next time.
Yeah, absolutely. Don't let him go. Chhodna nahi.
Welcome. I'll push him and you take it from there.
Yes, sir.
We're trying to build some sort of a team. If we can get 5-6 people and see, we can do some interesting things.
Yes, sir. Yes, sir.
Thanks a ton for giving me this opportunity. Cutting out on Dr. Hazra's time.
And Dr. Smith, I suppose we were planned to talk about pudendal artery thing also, or?
Maybe next time you can present. That's the biggest problem, or that's the biggest complaint Punjabis would have in Punjab. There's a good movie
Don't
called
speak
Aloo
too much
Chaat.
about it. Next thing will be accused of inappropriate angioplasty to the pudendal artery.
There is a good movie called Aloo Chaat. If you haven't seen it, just watch.
Okay.
Great movie, great comedy.
Is that the treatment for pudendal artery thing, or what you are referring to?
There's a doctor in that who's prospering on pudendal artery.
I mean,
It's a great movie. You'll enjoy it. I think everyone would be now wishing that they get a hanging stent in left main into aorta.
No.
Interesting.
I'll send them to Bali, sir. No problem.
Right, sir. Then next, if I think, sir, we'll have more. Intervention makes it more interesting than the lecture bangis. So we'll try
Smith,
to
I
have.
think we should have a combination. I think we should encourage others also to bring 1 or 2 cases each time.
Yes, sir.
Whenever we have a lecture, you detail somebody, you bring one interesting case so that we can see it, and it's always great to see beautiful cases done by everybody. Everybody is doing great work, and it will be really nice to see.
Even if the work is not great, sir, even if it's a textbook thing also, there is always something that we can learn.
Yeah.
So many great masters there. We can always learn something new.
I mean, yeah, we all learn from each other, Smith. It's great.
Yes,
If somebody doing something in a small center using only his hands and his mind and his imagination and what are the tools available, it's as joyful as watching a complex procedure done with all kinds of support and 3 layers of people supporting him. We appreciate that as well.
Yes. So I'll try to catch hold of few people who can present next time, and then we'll make it some kind of a roster kind of thing that everyone has to get involved.
Absolutely. Detail them.
Great. Thanks.
Right. Good night, sir.
Good.
Thank you, sir.
Thank you.
Thanks, Smith.
Sir, thank you.
Good night, everyone.